Good morning, good morning. Thank you all for joining today. I am Chairperson Felicia Porter, representing the 10th District, Chair of the Public Health and Environment Committee. As a reminder, please turn off or mute your cell phones. Today, joining the committee, we have Mark Conway, 4th District.
Thank you, Madam Chair.
We have Odette Ramos, 14th District.
Thank you, Madam Chair.
We also have Mark Parker, 1st District.
Thank you, Madam Chair.
We have representatives from the mayor's office and also city council president's office, and our staff person is Marguerite Curran. Thank you. So today we're reconvening a hearing for the legislative oversight hearing for the city's response to the opioid crisis. And as a reminder, this is an opportunity to provide a platform to city agencies, healthcare providers, community advocates to discuss the ongoing challenges, identify service gaps, and explore policy solutions to enhance Baltimore's collective response to opioid addiction and overdose prevention. The first hearing was held on July 9th, 2025. As mentioned in previous hearings, we'll first start with public testimony. So would anybody like to testify before we get started into agency reports? Yep. You'll have 2 minutes to testify.
Thank you so much. Morning. Good to see y'all. My name is Darcy. I'm with Baltimore Harm Reduction Coalition. We are a syringe service program. So for the last several years, we do overdose prevention outreach in areas like Penn North, along Maryland Avenue, and in Hampton, often in collaboration and partnership with local churches or religious organizations. So back in the summer, we do, like we do every Tuesday and Thursday, our services team was in Penn North at the time of the first mass overdose. We were about a block away when we started to hear the sirens. It is not news to anyone that these events are traumatic. It's traumatic for the people who are overdosing, for people who use drugs in the area, who are seeing their friends and family and loved ones overdose, for the first responders, for the community who has to go through these events, for the service providers who are there on site. And so for me and for an organization, it just highlights the crucial need for public health solutions, as this body has talked about. We know that when there is a large rate of drugs that are taken off the street, that can have the opposite effect of increasing overdoses in that area, that it actually moves people to riskier areas and destabilizes them. And so the public health solutions, if our goal is to focus on quality of life and people continuing to live and continue on their road of recovery, the public health solution really is priority. And so with that, we have to look at continuing the services we have throughout Baltimore. So that can be harm reduction, that's recovery, that is poverty alleviation, food, housing. Having those services continue is essential. And then having an acute rapid response, especially since we're seeing a more toxic drug supply continue, having those type of solutions is essential, and having those coordinated acute rapid response is essential. And then also having new tools in the toolbox. The drug supply is constantly changing and will continue to change. And so having things like overdose prevention centers that we've talked about a lot, that the situation could have looked very differently over the summer and even 2 weeks ago, where we're having drug testing, rapid response, we have wraparound services, and making sure that people are getting their information from trusted sources in their community that has been like a framework and a place to go, rather than it being sensationalized on the news and have that trauma continue and continue.
Thank you so much, Darcy. And just wanted to elevate many of the things that you were saying. I know a few of you all could not hear online, and so we apologize for that. You talked about poverty alleviation. You talked about different harm reduction and public health strategies. And that's everything that we are trying to develop within these legislative oversight hearings. And so we're doing it not only in partnership with each of the committee members, but we're also doing it in partnership with government and community-based organizations as well. And I I want to segue into my opening remarks. Thank you so much. I want to segue into my opening remarks as it relates to this legislative oversight hearing. So we are focused on the second half of the city's response to the opioid crisis, but as I've given direction to the agencies today, we're really focused on those mass overdoses that we've seen in the Penn North area. Particularly, what I will be focused on is making sure that we, one, have an understanding of what happened from a timeline and operational perspective, but number two, I understand that the overdose prevention strategy and plan is underway, and we've clearly got some work to do. And so having that highlighted within your presentations and just remarks in general are going to be very important. They're going to be very important not only for the community's perspective, but also for the oversight of this plan moving forward after this iteration of the oversight hearings. So, are there any other persons wanting to testify before we turn it over to our agencies? Great. We will close public testimony, and now we will turn it over to our agencies.
Good morning, Chair Porter, members of the committee. We do have a presentation that I believe Ms. Marguerite is pulling up, but before we get started, my name is Dr. Letitia DeRosa, and I'm the Deputy Mayor for Health and Human Services. I'm accompanied today by my colleague, Dr. Michelle Taylor, the Commissioner of Health for Baltimore City. Thank you again for this opportunity to discuss the city's ongoing response to the opioid crisis with a specific focus on recent mass overdose events. Great, thank you. Next slide. So this is a quick overview of our agenda for the morning. We will define some terms as it relates to overdoses and clusters. We will also be reviewing the different mass overdose events, beginning with the event on July 10th. We'll provide an overview of the immediate response as well as the ongoing, what I would call post-clinical response. We will discuss the mass overdose response planning and coordination that's been taking place, ongoing engagement from multiple city agencies, as well as the most recent mass overdose event on October 8th, and updates to the citywide overdose response strategic plan. Next slide. So starting with definitions, we would define an overdose cluster as a geographic group of overdose reversals greater than one would expect for a given area of time. So this is typically about 3 3/4 mile within 1 to 7 days. We are still refining the definition of mass overdose, but as it stands now, we would say that it's about 5 overdoses in a discrete time period in a defined geographic area. This could be a neighborhood, this could be a CSA, and this will trigger the mass overdose rapid response protocol that we'll discuss a little bit later in the presentation. I think one caveat that I will add here is that if our colleagues in EMS are in the field and have concerns, but the number is lower, we would still enact the mass overdose rapid response protocol in the event that they requested it. Next slide. So this provides, again, just a high-level overview of the timeline, beginning with the initial mass overdose event that occurred on July 10th. We had the additional events that took place on July 18th, and the most recent event, which occurred on October 8th. Next slide. So diving into a bit more detail for the event that occurred on July 10th, EMS received the first call around 9:20 a.m. And dispatched units to the Penn North area. Notably, this event was striking for 2 reasons. One, there were a large number of people involved, and 2, many of the people involved had what we would call atypical presentations, meaning they weren't particularly responsive to naloxone or the Narcan. So EMS noted this and subsequently sent additional units to the scene. Next slide. We see that in total, about 27 patients were transported by EMS. 5 were actually triaged by the healthcare on the spot van, and then 3 refused transport. To quickly go through the different priority levels for those patients, 7 of them were priority 1. which means that they required ventilation throughout their assessment, treatment, and transport, even after receiving naloxone. About 15 of them were priority 2, which means they did not require ventilation. However, they did remain unconscious or semi-conscious following naloxone administration. And then about 5 were what we will call priority 3, and they did regain consciousness following the naloxone administration. Next slide. At the scene, both the health department and BPD collected samples, and the results indicated a mix of acetaminophen, caffeine, fentanyl, mannitol, methylclonazepam, and quinine. I do want to again point out, specifically in this case, the methylclonazepam, which is a benzodiazepine, which can cause respiratory depression, which explains why some individuals were not so responsive to the naloxone. Additionally, we sent out a clinical letter once we had the mix available. We sent out a clinical letter to providers so that they would know how to respond in the event that they saw individuals presenting with similar symptoms. Next slide. So again, following that immediate acute medical response, several city agencies provided ongoing post-clinical support. Next slide. So even on that day, we had BC Moore, the health department, fire, BPD, and multiple other city agencies that arrived pretty quickly to the scene. As I noted before, the healthcare on the spot van that's run by the health department in partnership with Hopkins was pretty close by, so they were also able to get there pretty quickly. And we established what's called a field coordination site at the Enoch Pratt Library. From July 10th to July 25th, there was daily coordination of outreach efforts. This included both city agencies as well as community partners. We had more than 500 volunteers with 30 organizations across the state. We were able to distribute more than 4,000 naloxone kits, more than 2,500 fentanyl test strips, more than 750 xylazine test strips, and 600 hygiene kits were also passed out. So in addition to both this harm reduction kind of saturation of the community, there was messaging that was being distributed. We provided resources such as food, water, access to cooling buses, and we had many of our partner agencies that helped with connecting residents to other resources such as housing or employment services. We also had peers available to connect individuals to treatment. Next slide. I'll now turn it over to my colleague, Dr. Taylor.
Good morning. Now I'm going to discuss the ongoing internal mass overdose rapid response planning and coordination that has been going on since July 11th. Next slide. On July 14th, the Health Department, BC Moore, OEM, the Mayor's Office, the Fire Department, the Police Department, Law, Homeless Services, BHSB, and MONSE conducted a hot wash. This is a standard practice after an incident to identify strengths and areas of improvement, and there were 4 main strengths identified. The first was rapid mobilization, meaning that EMS, the Health Department, the Mayor's Office, and other city agencies and community partners quickly activated. Outreach began within hours, and triage and overdose reversal efforts began immediately. The second was effective canvassing and naloxone distribution. The multi-day effort reached affected areas with harm reduction education and supplies in coordination with community partners. The third strength identified was resource coordination. The state fulfilled our request for naloxone that same day. The healthcare on the spot van adapted when EMS needed support. And there was a commitment to recovery. That's the fourth strength, and probably the most important. Planning was almost immediately underway for training and response protocols. And as you can imagine, whenever you have that many people on a scene, the fact that these strengths were identified is just testament to the preparation of all of these agencies. An opportunity for improvement was the need for a mass overdose rapid response protocol and training additional city executive leadership in the ICS protocol. And of course, all of you all know that that's really the purpose of a hot wash. What went well, what didn't go so well, and what can we improve upon? Next slide. So as a result, a draft mass overdose rapid response protocol is in development. The health department is leading the creation of that mass overdose rapid response protocol, and the purpose of the protocol is fourfold. 1, to ensure a rapid, coordinated response to mass overdose events. 2, to reduce fatalities and long-term harm. 3, to expand access to treatment and recovery services. And 4, to promote equitable service delivery and reduce stigma. Next slide. To give you all a high-level overview of the current draft protocol, you'll see that the very first thing is the number of overdoses in a particular area that triggers activation of the protocol. And like Dr. Jaraza shared, that is still being refined. And of course, if we have a large number of overdoses in a very short period of time, whether it's 5 or 10, you know that we're going to respond. Our epidemiologists, Office of Public Health Preparedness and Response, and Office of Overdose Policy and Strategy are collaborating to define the number of overdoses in a defined area that will trigger the protocol. This is a complex determination as various areas of the city look different. For example, in some areas of the city, 5 overdoses is actually a daily occurrence, unfortunately. As the response is triggered, EMS will initiate their mass casualty incident protocol, and OEM will open the Emergency Operations Center to partial activation. This triggers an interagency response to major incidents. The Baltimore City Health Department is working with OEM on a notification system for the responding agencies. At the same time, the health department notifies area hospitals. This will dovetail with enhanced provider outreach and post-work with hospitals to ensure they are apprised of any changes in the drug supply that may lead to increased overdoses. And this is super important. If you talk to our hospital partners, they will let you know that whoever is transported, you have to be able to tell the providers as quickly as possible what is in the drug supply so that they know not only how to respond immediately to them when they come into the hospital, but what kind of discharge instructions they should give. Once the EOC is activated, agencies establish an incident command system. This is a standardized, on-scene, all-risk incident management concept that city agency employees are trained in. As part of this, the designated public information officer stands up a joint information center, and agencies establish a field coordination site in the affected area. Next slide. Now, this gives you a high-level overview, once again, of the 6 main areas that we will focus on in the rapid response protocol. The first is medical monitoring. The health department will work with EMS and the incident command to determine whether medical monitoring is needed to support people using drugs in the incident area. This would look like monitoring vitals, administering oxygen, and providing basic first aid, wound care, water, and naloxone. The second is canvassing and outreach. Something we did really well during and following the July 10th incident was our volunteer mobilization and harm reduction supply distribution. The protocol will formalize this with volunteers working in shifts between 9 a.m. and 9 p.m. to distribute harm reduction supplies like Narcan, test strips, hygiene kits, and wound care kits. All volunteers will receive just-in-time training. This is short and to-the-point training done when volunteers report to fulfill a position to prepare them for the role. And I can tell you that that was very much in effect on October 8th, and you could tell that there were a lot of lessons learned from July 10th. The third is real-time communication and data collection. During the response, we will gather data to help inform the incident commander. Data will include daily overdose-related metrics from EMS in the hospitals and Narcan use, reversals, and EMS responses in real time. The Health Department's Division of Public Behavioral Health and Chief Epidemiologist will establish best practices to retrieve and share data internally and externally. The next one is public communication strategy. Something else that was done really well in July was public communication about the event, including harm reduction messaging led by BC Moore. We'll build on and formalize this as part of the rapid response protocol. The public communication strategy will focus on using emergency messaging through multiple forms of media, such as flyers, a press release, a press conference, and social media. The messaging will prioritize harm reduction and risk reduction techniques, including never use alone, test your drugs, and carry Narcan. We will also do a Good Samaritan Law awareness campaign. The Good Samaritan Law protects individuals who help during an overdose, as well as the person experiencing the overdose, from being arrested or prosecuted for certain crimes. It is important for people to know that they will not get in trouble for administering naloxone or calling 911. Next is logistics support. Logistics will be led by OEM. This will include being responsible for acquiring space, supplies, and equipment, as well as site setup. And finally, recovery and long-term engagement. Once the imminent threat has been eliminated, canvassing and outreach will continue until naloxone or Narcan distribution has reached saturation. This may take 1 to 2 weeks, depending on the size of the incident. Having a continued community presence will be important for 1 to 2 weeks concluding the response to ensure community support. After the response has concluded, BC Moore and the Health Department will transition community outreach and support to MONSE for long-term community engagement and resources. BC Moore and the Health Department will partner with MONSE to inform development of long-term goals. And now I will pass it back to Dr. Shiraza.
Great, thank you, Dr. Taylor. Next slide. So again, going back to our timeline, we obviously had that period between July 10th and the 25th, where there was ongoing outreach and coordination efforts. But then, of course, we had a second mass overdose event within that window. Next slide. So just the day prior, BC Moore had actually convened an opioid restitution fund listening session at Gethsemane Baptist Church. And this certainly was to hear about the community's feedback on the existence overdose response strategic plan, but also to receive additional feedback on how the response had been since July 10th. Next slide. So then we had the second overdose event, mass overdose event on July 18th, in which 5 people were hospitalized and 2 people declined transport. I think what's really important to note is that many city agencies and community partners were actually already on the site. So you see them in this picture in the field coordination site, mobilized and ready to go. So we really had a number of people already in place so that they could be rapidly deployed to help with additional saturation of harm reduction messaging and connecting community to resources. During this particular incident, BPD actually assumed incident command responsibilities. Next slide. As Dr. Taylor noted, MONSE has been, and I think will continue to be, a very critical partner in this work, given their long-term goals around neighborhood stabilization, even though we know this is a different type of event. So MONSE quickly put on an initial resource fair at the end of July, has subsequently done multiple events supporting workforce development and connecting individuals to work opportunities. They've also brought in Misha House, a partner that provides drug treatment services. Next slide. So this just represents a list of some of the ongoing activities supported by MONSE and partners. And you can see that they've been engaged most recently as October 16th. In total, they've held 18 in-person events, 15 canvassing events, with more than 700 attendees at all events. Next slide.
And to dovetail with what MONSE is doing, the Health Department is also doing all the work we just discussed, but we also continue to provide all our services and programming, including street outreach. We also continue to conduct data analysis and surveillance, and this is important because we have seen a sustained increase in non-fatal overdoses, which we have published on our dashboard. North, Mondawmin, downtown, and Park Heights have been especially heightened. We use this information to direct our outreach activities to these areas, in addition to maintaining our outreach in other high-need areas, keeping in mind that our response is shaped by the resources we have. We are also looking at how we can leverage other teams within the Health Department to support these areas, like our STI prevention team. As we've shared previously with the Council, we are working with the Maryland Department of Health to be able to disseminate information on fatal and non-fatal overdoses publicly. And we're working on those data use agreements as we speak. We continue to participate in community blitzes led by the police department. Blitzes are BPD-led initiatives through which a multi-agency task force addresses issues like illegal dumping, abandoned vehicles, and substance use. The task force does a community walkthrough every 2 weeks and meets weekly to debrief and follow up on the previous blitz and plan the next week's blitz. Our Community Risk Reduction Services team joins these blitzes to engage people who use drugs and residents overall, offering services that include overdose education and naloxone distribution, referrals to treatment, and syringe surveillance and cleanup. The team also uses these as an opportunity to assess different areas of the city and see if they might benefit from our routine services. In April 2025, the group completed its 40th Community Blitz. We, of course, continue to collaborate with community organizations. We are partnering with CBOs such as Be More Power and Community Peer Project to assist with canvassing efforts in response to mass overdose events. In general, our Community Risk Reduction Services has a strong foundation in community engagement and outreach. The program actively participates in several work groups and initiatives to include the Public Health Outreach Work Group, Multi-Agency Inspection Task Force, the Downtown Stat Work Group, the Lexington Market Initiative Work Group, and the McElderry Park Safety and Wellness. We are working with the fire department to develop a new public alert system for when there are 3 or more overdose reversals within a zip code in a calendar day. And as you can imagine, we are being very intentional about working with them to make sure that we're not alarming the public, but we do want the public to be informed. And as already discussed, we are developing a mass overdose rapid response protocol. Dr. Shiraza?
Next slide. So again, going back to our timeline, we will spend just a few minutes. I'll actually turn it back over to Dr. Taylor to talk about the most recent event on October 8th.
So the October 8th event was actually my first mass overdose event in the role. And as a summary, we had 11 overdoses reported, 7 people were hospitalized. The health department and BC Moore were on the scene immediately and through the next day to coordinate rapid response outreach with community partners. And we conducted a hot wash the very next day to make sure that we discussed immediately what lessons had been learned from the previous events and what we could do better after October 8th. And what I can tell you is I'm very proud of not only the health department team, but the excellent coordination between agencies. Everybody was on the scene. It was all hands on deck. And just being the new person coming in, I could tell that a lot of lessons had been learned. Almost immediately, it was, okay, you do this, you do this. People were on the scene. It was very organized. The volunteers that showed up knew where to go for the command center across the street in the library. And it couldn't have been a better run event. And I think that's a testament to all of the hard work that has been done up until this point.
Next slide. And then next slide. So there are a lot of words on this slide, but I think the big takeaway is that the way that we are viewing our response to mass overdose events is it is a part of our broader response to the overdose crisis that the city is experiencing. So we know that, of course, there is this acute, immediate clinical response, this post-clinical response in the setting of a mass overdose event, but we also have to make sure that we're tying it back to the larger strategy, which is focused on harm reduction generally, which is focused on looking at neighborhoods that have been disproportionately impacted already, even outside of mass overdose events, and making sure that there are low barrier access to treatment services, ensuring that there is recovery centers available to take individuals for treatment and on demand. So just want to note that, yes, we have this mass overdose rapid response protocol that's being developed, but it's a part of our broader strategic plan. I also just want to quickly highlight two key events that have happened since the mass overdoses, which is the first is the announcement of the Naloxone Neighbors Program, which was launched on Overdose Awareness Day, which is essentially a train-the-trainer model, where we are, again, looking at communities that have already been pretty disproportionately impacted by the overdose crisis and working with neighborhood and community leaders to train them on naloxone use, and they can subsequently do door knocking and train individuals in the community on naloxone use. While I know when we think of overdoses, we often think of them happening in the street, 6 out of 10 overdoses we see actually happen in someone's home. So we know that it's really important that we check on our neighbors, but also make sure that neighbors have the tools they need to prevent overdoses. The other announcement that will be coming soon is a partnership between the city as well as MTA and the Maryland Peer Advisory Council. Again, just I don't want to spoil it because the mayor will be announcing it really soon, but it's another opportunity to increase access to naloxone and other harm reduction tools. Next slide. And then lastly, I would be remiss not to announce the community grants that RAB will be distributing. So there was an announcement on October 9th, the day after the most recent mass overdose events, that focused on the RFP that will be released on October 23rd for community-based organizations. And the RAB decided to focus on 3 primary areas that are already listed in our strategic plan: low barrier mobile treatment services, low barrier harm reduction services, and again, low barrier social support services. So proposals are due, initial proposals are due on November 23rd, and individual organizations that are selected to participate will be notified with subsequent final applications being due on January 23rd, or January 26th. Next slide. So in closing, there is still a lot of work ahead of us. I think we can all agree to that. In the same way that we can agree that one overdose is one too many, but I would be remiss if I did not take the time to thank all of our city agencies, all of our partners. I have no doubt that there are lives that were absolutely saved because people were there at Penn and North on July 10th and have been there ever since. So thank you all.
Thank you so much, Dr. DeRosa and Dr. Taylor. Before we go into questions, I want to have 2 official committee requests that I just want to make sure we handle. The mass overdose protocol, do we have an ETA on that?
We can get you that. We can get you that. I think, we had it developed back in July after that initial hot wash. Some of it is we've had 2 overdoses since then, and so I think we want to make sure that we're incorporating lessons learned and know that it will be revised. But we can actually get you a date on that.
So Tylor, if you are listening, if we can have a date shared back with the committee, thank you, with the committee in about a week or so. I'm hoping that mass overdose, thank you so much, Tylor. I'm hoping that we can have that mass overdose protocol completed by the end of the year. And so definitely want to make sure we have it completed by the end of the year and enforceable, not enforceable, but in the implementation phase. The next one is the ETA on the data use agreements. Do we have an ETA on that?
Well, I can't give you that as quickly as I would like. So I have had initial meetings with the head of Maryland Department of Health and the Deputy Secretary, Meg Sullivan, to start those conversations. Of course, the Health Department team has been working on this for quite a while. Everybody has been amenable to working on it. And so I can't say by the end of the year, but everybody is in agreement that those data use agreements need to be updated to allow us to share more information. So as soon as I get an ETA, I will definitely share it.
Thank you, Tylor. If we can make sure that on a monthly basis, we have a status update on that ETA, on that data use agreement.
Yes, ma'am, will do.
Thank you. I first want to also recognize my colleagues for joining, Councilman Torrance from the 7th District, and then also Councilman Ryan Dorsey from the 3rd District. Colleagues, just as a reminder, we'll have an opportunity for 2 questions each related to this presentation today. Again, 2 questions each related to this presentation today. As we go through our line of questioning, please make sure that your questions are very succinct so that we can get as much in as possible in the time that we have together. So I'll first start off, Dr. DeRosa, excuse me. I want to talk through the surveillance mechanisms that the city utilized as it relates to the notification of the mass overdose. So we understand that the National Institute of Standards and Toxicology, they have a state-level surveillance system that looks at new and emerging drugs and, coming into systems. How are we utilizing that system for our local partners here?
Yeah, I think that's a good question, and I may start, but then we do have some colleagues here from the health department who might be able to get a little bit more granular. So in general, the city, the health department, BC Moore has frequent communication with both kind of local and federal partners. So even going back to the July 10th incident, BC Moore was notified of what substances were in the drugs. Already there were ongoing conversations with regional partners about what they had been seeing. And so those are actively happening. Now, as I would say, getting a little bit more granular, I might turn it over to my health department colleagues.
And I would appreciate a more detailed approach because one of the major issues that we're running into is there were a lot of drugs that were mentioned, and there were a lot of new and emerging drugs that the test kits that we are handing out are not necessarily testing for. Yeah. And so, if you can get Dr. Taylor, if you can get a little bit more granular about their surveillance mechanism, that would be great.
Well, I will do my best, but I also have some support in the back of the room to help with that answer. But what I will tell you is that the drug supply is constantly changing. There's no way that we would ever be able to procure enough testing kits to test for everything that could possibly be in there. In short, we're dealing with a drug market where they are constantly changing. There's different synthetics. There's different ways that they're trying to, keep people in this circle of substance use. And because of that, we do our best to try to work with partners to know what's going on, work with the state. But then also, I can tell you from my initial conversations with MDH, one of the things that they get concerned about is, given our current federal landscape, they have to be very careful even when they share information with us, because the attitude is that we shouldn't be doing any harm reduction strategies at all, to include figuring out what's in drugs, right? And so a lot of times what MDH is doing is really blocking and tackling for local jurisdictions to make sure that we can continue to provide these services, to include reporting what's in the drug supply. And so I've had these initial conversations with them. If I'm not answering the question just the way you want it, of course, we have health department people who can answer even more clearly.
And the reason why I bring up the testing kits, because as we've all seen during the budgetary process, we spend a lot of money on the testing kits that we do have within the health department. But we have seen for at least a number of years that benzos and other stimulants have been in the market for some time. And so one of the very interesting parts that I saw in that drug mix was that we had benzos and stimulants within the drug mix. And so testing for it, if there's any way to test for that in an upcoming mass overdose, we would not be able to test for that. And so I'm trying to figure out what the protocol is for these new and emerging drugs that have been in the market for about 5 or so years now. How can we engage those drugs into our current protocol that we're developing for the city?
I think that's a reasonable question. I do, I guess, just want to make one note that, specifically as it relates to like fentanyl and xylazine, which are test strips that we do distribute, those are still very much in most of the drug supply. So I do think it's just important to note that fentanyl is still pretty significant when we think about the cause of most overdoses. We're seeing this emerge, but I think that it's just still important to note that.
Yeah.
And then we also know that specifically with xylazine, that we see some pretty significant wounds associated with xylazine
Yes.
use. So I do want to still highlight the importance of
importance, yes.
continuing
Yep.
with the current test strips that we do have. But
Sure.
appreciate that question, and certainly I think it's one that we can take back.
Sure, and the reason why I say this is because I don't want to underscore that fentanyl is not an important drug that can detect, that we are seeing in majority of our overdoses, but we are seeing those new and emerging drugs, and we're getting our community scientists are getting a lot more creative with how they are utilizing and integrating these drugs within the supply. And I think that it makes it even harder to detect on the back end if we are not looking at all of the new, all of the trends of those emerging drugs. The next question that I have, and this is something that I want to be mindful of as well. When we're talking about harm reduction, I noticed that a lot of the conversation deals with syringe distribution. Talk to me about what your definition of harm reduction is, and I want to focus on the not only the broad definition, but the full definition of harm reduction, because I think sometimes it gets missed in these conversations when we are talking about drug use, drug overdose as well.
Sure. Maybe I'll start and certainly hand it over to my colleague, Dr. Taylor. So at least I think about harm reduction on a spectrum, right? And so harm reduction certainly could be the distribution of syringes. Harm reduction could be ensuring that people can use safely with a partner or friend close by. Harm reduction could be making sure that a community is saturated with naloxone. Harm reduction could be messaging that reduces stigma. Harm reduction could be overdose prevention sites. So I think that there is a spectrum, at least when I think about harm reduction. But I think what I also keep in mind is meeting people where they are. And so when we think of individuals with substance use disorder, they are also on a spectrum, some who may be closer to entering into treatment, some who wish to continue to use substances, and we want to make sure that they are using as safely as possible. So that's how I generally think about harm reduction.
And to add to that, what I would tell you is that because syringes have become a focus of harm reduction, people don't realize that when we give out harm reduction kits, it's not just syringes and saline, right? We're giving deodorant, we're giving soap, we're giving toothbrushes, toothpaste, we're giving, personal hygiene things, right? We're testing folks for STIs. One of the things that I have really enjoyed about my orientation with the health department staff is Baltimore was on the cutting edge of starting harm reduction efforts. And because of that, Baltimore has seen significant decreases in HIV infections due to due to needle use in shooting up drugs, right? So when you talk about that, when you talk about the fact that harm reduction really is on a spectrum, like Dr. Terraza said, it's not just, giving out syringes and saline, because we know how some people feel about that in the community. It really is about saving people's lives, right? By making sure that they can use safely, making sure that they don't have some of these other sequelae that go along with using drugs, making sure that they have the personal hygiene things that they need to cut down on wounds and other things and things that can happen when you are using. But also making sure that you can get people to a place where if they choose to enter treatment and choose to try to enter recovery, they can do so. So really, there needs to be an education campaign around the broad definition of harm reduction. It's a great question.
And I agree with you. And I will also add, there has to be, and I've been saying this at a few hearings, there has to be a marrying of government resources and oversight within harm reduction from an agency perspective, because not only is it just making sure that the quality of life for the individuals, we also need to make sure that we have the quality of life issues for community as well. So we're talking about sanitation, we're talking about about making sure the cleanup of just other issues that are permeating in community as a result of what we're seeing. And lastly, making sure that we're providing sustainable methods and accountability from providers to make sure that these individuals are exactly going into treatment. And for the public's knowledge, you all will begin to see a way and a vision of how we can make sure we have that marrying of government resources and services along with harm reduction. We can't do this in silo. We have to do this from a whole agency coordination approach. I'm gonna turn it over. I'm gonna defer to Councilman Torrance. Given that this is his district, I'll let him start us open with questions.
Thank you, Madam Chair. I'm just going to start with comments first. I just want the men and women who are in the rear of this chamber to say thank you, because I saw firsthand each time your work. My community members have experienced it in a way where they appreciate you. The chair and I both walked some alleys in Penn North and provided Narcan, but also provided opportunities and resources for people. They know our community workers well, and they also respect them because they don't judge them and they have compassion for them. And I just want to say thank you. That is the hardest part. A lot of people don't know my personal story. My mom used to buy drugs from Pennsylvania North Avenue. So it is near and dear to me to treat people with the respect and the compassion that's needed, because rock bottom does not hit everybody. And to have Powell Outreach, as well as the Peace Team and others who have been good actors who are on the ground and are trusted people in the neighborhood, I now see people walking around in Pennsylvania and North Avenue with Narcan. I now have people saying that they feel safe because they know that they have a resource through our peer navigators. I've even seen our peer navigator put someone in their car and take them to recovery because of how we've done our response. I even seen your epidemiologists respond to the data that they were given by the fire department immediately, so that we made sure our teams were going to the right locations and to the right people. Now I'm gonna ask my questions, Madam Chair. Given where we are, I wholeheartedly have to say that I think the next phase, because we have that trust, we have the opportunity, I think we need to really go deeper in terms of response. How are we coordinating with DCHD and others around the strategies that we have currently in Penn North in terms of our housing strategies, in terms of providing people opportunity? Because what we're seeing is a number of the persons who are connected to this are not residents of Pennsylvania North Avenue. So how are we connecting them to the housing resources? I say that like as a public crisis, but how are we connecting them to the right housing opportunities? And I think that that's the next phase. How do we connect them to the next resource? We have recovery, but some people aren't ready for recovery. How do we connect them to housing? So have we discussed that interagency-wise, how we're gonna connect them to that resource?
Sure, thank you, Councilman. And that's something we can definitely take back. What I will say is DHCD was an active partner, just going back to, again, the initial response and helping with clearing vacants. I didn't mention that in the presentation, but I think that's also important to note. And to your point, you're talking about the social drivers of health, right? How are we making sure that people have a place to live? Homeless services has also been pretty engaged in this area as well. But I take your point, and I think that we can come back with some additional strategies and ways to better engage DHCD, ways to better engage homeless services.
And wholeheartedly thank you for that. The other piece is I want to go a step deeper. I have, even with talking to the state, I think we need to really do a deep dive into the data that we have on persons who are overdosing and see if they're connected to bad actors that are PRPs, so that we can start cracking down on those organizations. I say that because I'm noticing a pattern. The persons who are overdosing in my community are typically not from West Baltimore or not citizens of the city of Baltimore. I'll give you an example that one young lady is from West Virginia. She was brought here by a PRP that has since closed. She had housing in Liberty Square and no longer has housing. But she was being given treatment through Medicaid. I think that we really need to have a conversation with our federal partners as well as our state level partners about tracking those persons who are receiving treatment and start removing those resources. My question is, will you join me in having that conversation with our state partners? Because I think that we need to do like we did with the ACA and start funding people based off of who's getting healthy and then who's actually getting the services that allows them to be not hospitalized or having overdoses.
Sure, thank you for that. So I think two ways that I'll address that. So we have had discussions, again, I think Dr. Taylor mentioned this, with the state, specifically around PDMP data, which is the prescribing data, to better understand prescribing practices. And so that is something that we would love to have additional access to. It's been challenging, but we would love to have additional access so that we can know who is prescribing what to whom, because I think that's a little bit about what you're getting at. As a part of the broader strategic plan, there is mention of looking at different recovery treatment programs and assessing the level of quality. We know that that's it's complex, right? So this is somewhat regulated by the state, but it certainly is on the radar, I think, of our broader plan to look at the quality of those organizations. And similar to what the health department has done in the past with having different, what we call levels of care for hospitals who provide services, is there a similar model that can be applied to recovery treatment programs?
And I agree with you because I'm a steward of observations. If you go to Jai Medical Center on York Road, there's an issue there. If you go into other locations across our city, there are treatment programs where there are open air drug markets that are actively targeting people. I just want to be transparent because I have two that just opened up on Pennsylvania Avenue near Pennsylvania and Lawrence Street. These are the intentionalities, and this council a few days ago voted on a parking policy that will allow more of them to come to that actual intersection. So I just want to make sure that my colleagues hear me when I say this. Our votes and our policies have consequences.
Thank you so much, Councilman Parker.
Thank you all very much for being here, and thank you to Madam Chair for continuing these important conversations. Thank you, Councilperson Torrance, for sharing your experiences and what's at stake right now and moving forward. I know that part of the response this summer was community listening sessions, and you covered a few of those in your presentations. Would you return to those a little bit and share a little bit about what in particular you all heard? What were the big takeaways, and how has that shaped this next iteration of the mass overdose response or other aspects of our work here?
Sure, thank you for that. And I actually may phone a friend from the BC Moore office. So those were led by BC Moore in partnership with the health department. And I know that they received a lot of data and have taken great strides to analyze it. So I don't want to misspeak. I don't know if Miles is able to come up and just share very generally about some of the key takeaways.
Thank you. I think it would be preliminary for us to be providing too much information at this point about all of the details that were provided at each of those listening sessions. But I just want to provide you with an update on the steps that we are taking to make sure that we are implementing that feedback thoughtfully and strategically. There were, as you know, 5 priority areas in the strategic plan for listening sessions, and so it was a great deal of information to synthesize. Internally at the BC Moore office, we have worked through all of the notes that were collected at those listening sessions through the facilitators and through our staff that were present in partnership with BCHD. We have taken 2 steps to sort of process and synthesize that feedback. The first is working with the Restitution Advisory Board. At the last meeting that we had in September, we began working through the synthesized feedback across each of the 5 priority areas, and we will be continuing to do that at the upcoming Restitution Advisory Board meeting this month. And then internally, among city agencies, we have a weekly overdose working group that convenes the deputy mayor. It convenes BC More, BCHD, a number of offices, including sort of those focused on the social drivers or determinants of health, to continue to synthesize that feedback. And our next step will be taking all of that sort of aggregated work, both from the RAB and the interagency working group, and providing kind of discrete updates that we will make to the strategic plan and documented in sort of an appendix that will memorialize the specific steps that we've taken. At a high level, though, I will say we did hear, I think, generally positive feedback about the strategic plan. I think we recognize there's always more to do, and so I don't want to be, premature in sharing some of the updates we will make.
Thank you very much. Madam Chair, my second question, and so I'll preface it by saying, I recognize we're here as the Public Health and Environment Committee, and that we're speaking from a public health perspective, a harm reduction perspective, and my own background is in human services, social services. So I think that's always the primary lens that we're working with and that I'm working with here. And also, I will say that in addition, so when I hear about mass overdose events and like the ones we're describing today or discussing today, I certainly think about our responses and the humanity of the people involved and trying to keep folks safe and help people recover. I appreciated Councilperson Torrance's push towards some level of accountability for those who are contributing to the suffering of our neighbors and the depth of suffering and kind of the size of events like this. I can't help but think, I know our chairperson alluded to neighborhood scientists, I think, or something along those lines. I do wonder to what extent in the mass opioid response or overdose response protocols, I know BPD was mentioned a little bit as like co-incident commanders along with BCFD. To what extent, I can't help but think that there are people who in some way or another have actively contributed to poisoning our neighbors, right? And that, and I'm curious as to what part of this response, and again, the public safety officials aren't sitting here, but to the extent that you can describe it in terms of the plan, to what extent is there some accountability to that direction too? Again, without that being the dominant response at all. Sure. But when I see so many of our neighbors struck down, I can't help but think that whether it's local folks or whether it's broader organizations that have some responsibility for the fact that people have been poisoned.
Yeah, no, I appreciate that. I think you're talking about how are we integrating both our public health and our public safety response, which are both important when we see an incident like this. So I'll speak maybe generally, and I know there were some notes in the mass overdose response protocol draft, but I think the reason why we kind of made the health department and BPD co-command in that initial draft was for that very reason, right? Recognizing that the health department would really lead the public health response, lead the harm reduction response, and BPD would be responsible for the public safety elements. Is the scene secure, right? So thinking about all three of those incidents, are people kind of in and out of the scene, right? Are samples being collected? I know for those incidents, they discussed using drones, and I'll speak high level for BPD, but using drones to identify if there were people in some of the vacant properties as a part of their role. I think to your point, when we have cameras and surveillance, right? How is BPD evaluating that footage to identify, any culprits who may have contributed to what we're seeing? But I think that's the extent of how I can speak for BPD.
So I really appreciate that, and it's fine. I mean, I recognize that our public safety officials could get to could take the conversation in additional directions. I think and I appreciate all of those raised. I think my primary, when I think about kind of like accountability from a public safety standpoint, it's less the individuals in the neighborhood and more the systems or organizations which are responsible for the production and creation of the materials which are impacting our neighbors in that way. But
No.
yeah.
Yeah. Go ahead.
And I will credit our public safety partners because we've had 5 federal indictments at Pennsylvania North Avenue in the past 4 years and taken down over 100 people and 3 drug organizations. The issue is always going to be demand because as long as we have a demand, the supply is going to show up.
Yeah.
So this is a broader conversation. We're not going to police our way out of this. And I say this because there was just a case a few months ago where someone's home was taken because of their actually selling drugs in Penn North because of RICO, right? We've had organizations taken down. We got to figure out something more than just policing our way out of it. And I say this because we have it all the time. We had multiple felony arrests, over 100-something felony arrests post July 10th, right? We're still making arrests to today. I think we need to have an honest, appropriate conversation that we need to get people into recovery and not create, and the demand is what we have to start focusing on because we're going to keep attacking the suppliers.
And to follow up on that, I would even add, Councilman Parker, we need to actually really look at the system of how we do healthcare delivery as it relates to recovery. And so with regard to any type of accountability and/or accountability from some of these predatory providers, I think that's where we can relay we can lean into, from this committee, we can lean into our way of working together to provide those quality care metrics, to provide those zoning mechanisms whereby we are limiting and/or providing cover for the good actors and limiting those bad actors from flourishing in community. Because as we're seeing in the federal public health space in general, we're going to see a limit of funding sources on a number of fronts, including behavioral health. And so my hope is that working in collaboration with our local agencies, our state level partners, and even our federal level partners, we'll be able to provide those workflows of accountability that they'll just fall off. Yeah, that's my hope.
Thank you, Madam Chair, and thank you, Councilman Torrance, for the contributions there and for the work you all are doing outside of this conversation today to push us in those directions.
Definitely. All right, Councilman Conway?
Thank you, Madam Chair. And thank you guys for walking us through the sort of mass overdose response. I had a chance to be out there 2 out of 3 times and see the rapid response. And I want to take my hat off to you guys for just being there. I think we are incredibly lucky that this happened at Penn North, oddly, because we have a ton of resources there all the time. I was literally just there yesterday, and there are folks all over prepared to support folks should there be an overdose or any other emergency in that situation. And, despite, I think, the longstanding issues that we've had in that area, I think we've got a ton of resources there to support folks should there be an emergency like this again in the future. And I think that's probably the only reason why we didn't have any deaths. So I just want to take my hats off there. 2, I want to just nod to my colleagues and the conversation that was just had. I think one of the big issues that I've been talking about for a long time is how we strategically dismantle our open air drug markets. And I think that is much more than the police department. I've been saying this for a very long time. I think it takes a coordinated effort focused on supply and demand. It takes a bit of neighborhood development, development of people, providing opportunities for those young men often that are selling drugs out there, actually really good opportunities.
And women.
I'll wrap up this to get to my
I was
question.
saying, and women.
Yes, and women, absolutely. It had some conversations with some young men as I was out there yesterday looking for jobs. So I think there are opportunities here, and I just we're only talking to you, the health department, and a deputy mayor, and but I think we need that coordinated response, not just on overdoses, but the comprehensive look on how we deal with addiction in areas much like Penn North. That said, I wanted to get into an issue that I've been talking a lot about because I see this as an unfortunate event, but I think also an opportunity to continue to learn. We had 27 people overdose on the first event. We had 7 at the next event, and we had 11 at the last event. And I'm always thinking about systems. How do we change the system? we have our immediate response. I think we're doing a great job with naloxone, which is why we were able to save so many lives. And we're even seeing that naloxone is, and I said this before and got beat up a little bit about it, but the nature of the drugs that we're seeing on the street are not as pure or clean, and so it does affect the effectiveness of naloxone. So it makes me think about what we can do to change this for next time. And I've been talking a lot about buprenorphine as an opportunity for folks after they've received naloxone, they are in withdrawal, to help them take that next step, hopefully toward recovery. Now, they may choose not to. They may not be ready, as you said, Deputy Mayor. But it does give them an opportunity to choose, should we have that medication available on the scene. Today, we don't equip our paramedics with it. We have a bill that's in this committee and will be heard soon that will propose that. But we don't even necessarily need that. We have the spot van that offers low barrier buprenorphine already that can respond to these scenes. So I'll get to my question. It's a very easy one. It's a yes, no answer, so you don't have to give as much of a preface as I have. Do we currently, did we in any of these three, or would we consider perhaps having the spot van or any sort of low barrier buprenorphine options available after some of these events?
I'm pretty sure the spot van was available during this last event especially. I can't speak to the other two, but on October 8th, the spot van was available, yes.
Okay. And given you're not sure, you probably don't know the answer to this follow-up then, do we know how many people were engaged by folks in the spot van that were victims of an overdose?
That's a question I'd have to ask the staff to answer if they
Okay.
can. If they can't, what I would estimate is of the people transported, a lot of times the spot van wouldn't have a chance to respond to them immediately because they were transported to the hospital. And so a lot of times with the on-the-spot van, it's folks walking up. And if somebody's in active overdose, they can't necessarily do that, especially immediately after naloxone. But great question.
I actually may phone a friend as well. So we do have someone who previously worked on the Healthcare on the Spot van here, Mr. Bobby Harris. And so if he could come up and just give a little bit of context for the event.
And we want to congratulate you on your new position, even though you are not with the spot fan anymore. Thank you. Just want to preface that for all of the JHU people listening.
Excuse me? Oh, thank you. Yeah, no, thank you very much for having me. It's been an honor to be a part of the spot and a part of the city and the health department and JHU's partnership in trying to provide comprehensive services, not only to support treatment for opioid use disorder, but the wraparound services that are so important to really get at the root of a lot of the issues that we're seeing. On October 8th, the spot physically was at Charm City Care Connection as regularly scheduled, but we do have a telemedicine service as a part of our larger, broader service platform where we partner with the Baltimore City Fire Department's Population Health Unit, who responded that day, and their paramedic teams can contact that telemedicine line for anybody that they engage that are interested in on-the-spot treatment for opioid use disorder, which we've been successful with as a model and are interested in expanding. And recently, I believe that pathway into treatment engaged somebody in the Penn North area, which we're very excited about. And that also allows us an opportunity to work with that team to continue engagement in support of retention, because we know retention leads to a reduction in overdose risks over time. In July, our team was at Fremont and Lawrence at a regularly scheduled visit or regularly scheduled day, and were able to redeploy to the Penn North area and combine with some of the initial outreach effort where our team of nurses and nurse practitioners were able to engage with our peer partners in providing naloxone, and then worked with Healthcare for the Homeless, the population health team and other community-based organizations to set up the medical monitoring unit, which we were able to engage people in treatment post the response. So I think the healthcare on the spot is one tool, but really a part of a larger group of incredible resources at the health department to be able to provide that medical component to complement everything else that's happening that the health department can provide.
If I could clarify what I'm talking about, so we're looking at a bill that it's squarely focused on the moment after an overdose, after someone is given naloxone and now they're in withdrawal and maybe having one of the worst moments of their life. Buprenorphine can help them with those withdrawal symptoms, but also reduce the likelihood that they fall back into an overdose, or within the 24-hour period after taking the buprenorphine, can use opioids again effectively. And so the idea here is to help people who have, just barely were able to hold on to have a moment of clarity to figure out what their next step may be over the next 24 hours or so by offering them buprenorphine. What we've proposed, or the bill that I introduced, would equip paramedics in our emergency units, our ALS units, with that medication. But I do know the spot van offers low barrier buprenorphine to anyone who is interested, able, or willing to take it. And it sort of begs the question for me, when we have these overdose events, our paramedics don't currently have the medication, but the spot van does. And I'm curious if we've maybe considered the spot van offering that medication in that instance.
Yeah, I think it's a wonderful idea. I think this gets to figuring out ways when we're talking about mass casualty events where we can have comprehensive approaches to care. And the spot absolutely can be a part of a larger vision about how we can break out of traditional siloed approaches, where we can work together and bring city agencies and community-based organizations together to have one singular organized response. Sure. So I'm completely in favor of utilizing the spot services, but also the many other services that exist at the health department and already happening in the community to be able to work together to do that. But I would also make the argument too that we need to be there every single day. That we need to continue to use data-driven approaches to identify locations where we need to be comprehensively, but we also need to have that trust and the rapport by being present every day. So, we know the people who are in need, and when an event like this happens, we already have that trust and rapport, so we can respond to them.
Yeah, appreciate it. Yeah, thank you.
And to follow up with that, I know we've had this discussion before. One thing to remember is, at least on the EMS side, doing BUP right after naloxone does not fit into their protocol. It's not allowed by the state. And so that's the other thing that we would have to really work out with the on-the-spot van, is that, is that a protocol that they would also have to be beholden to, because currently an EMS protocol, that's just, they cannot do it. And so I would caution to,
We just got permission from MIMS to do that. But
And real
I'll
quick,
move
so
on.
we have another hearing for that?
Yeah,
And
we
so-
do have another.
Yes.
So my next question, we'll come back to that. Thank you. And maybe we can talk after. My next question is about the notification system. So we talked after the first event about the text notification system that existed maybe 4 years ago that lost funding. And we were going to look into what it might take to get that back off the ground. I'm curious, was it deployed here? I didn't see it mentioned in the presentation. And if not, do we have any update on, one, whether or not we're thinking about bringing that system back, two, what it might cost? I know it was a text system, which certain people got the text if there was an overdose. I'm just curious if that's something.
Yeah, maybe I'll talk generally, and certainly Dr. Taylor, if there's anything to add. So I think you're talking about Be More Alert.
Be More Alert, yes,
So Be
thank
More
you.
Alert. And And so two things. So there is the notification that would happen to individuals who would arrive on scene to provide additional care and support. In my mind, that is completely separate from like the broader like public notification. And during all of these events, there were lots of notification happening to multiple city agencies. So there was a lot of communication there. So I want to be clear that that happens. The other part of that is that the health department internally is aware of non-fatal overdoses. So they have access to EMS data, they have access to other data, and so there is an internal review of those data sources. Dr. Taylor, I think, mentioned developing, what it might look like to have broader notification in partnership with fire, and I think that's something that we're still kind of actively exploring to see how it might make sense in this case. But I just want to be clear, there is very much internal notification and discussion when we see these events.
Before you jump in, the question I have is, it was my understanding that text notification system was available to just sort of everyday people who may be using or have loved ones that are using and might just be notified that there's a bad batch on the street. I know we communicate very effectively. I mean, I was on the scene. I saw everybody was there and prepared to support where they can. My question here is about the people, folks who may be in the addiction space, folks who may be in that opioid space that can also be helpful and making sure they get that proper notification so they can jump in to help.
So like I mentioned, internal communications, great, you know that. External communications, we have to be a bit more careful. Now, with that said, internally, we are discussing that, but we understand that there are a lot of different considerations when we start talking about doing text alerts to a broader audience, right? Because we definitely, in this case, want to be trauma informed as well. With the public, there are some people who want to know everything, right? They want to know that what's going on. They want to know about the mass overdose. They want to know about it immediately. But there's another pretty significant sector where even receiving a text like that could be traumatizing. So really what we're doing right now internally is really being intentional about what does it look like to think about having another public alert system with the understanding that we want to provide clear information, but we also don't want to traumatize the public with constant alerts either, especially with what we know what's going on in our communities. So what I would say is that be patient with us. It definitely will not be called Bad Batch again, right? We know the name is going to change, but we also want to be responsible in how we do it and when we do it.
So we are considering bringing it back in some capacity.
There is consideration and talks about it.
And my thought here is, I don't know if it would go out to the public more broadly or not, but certainly I would imagine for folks like the Harm Reduction Coalition, they would be folks who can help us in areas where we can't. Maybe they don't want a city official to intervene, but they have that trust in that relationship where they can be helpful. But thank you, Madam Chair.
Thank you so much. Councilwoman Ramos?
Thank you, Madam Chair, and thanks for having us spend a lot of time on this. I really appreciate it. I have a technical question. Dr. Duraza and Dr. Taylor, you talked about one of the criteria for whether it's called mass or whatever is the reversal of overdoses. Now, Narcan does that, but that's not always a 911 call. So are we talking about whatever is a 911 call that becomes, because one of the things, I think it's great that we're doing naloxone and that more people are doing it. We're going to save a lot more lives, but we don't know what those numbers are that we're saving when we're asking people. So, it sounds like it's when the
It is. It's when we get the data. So
Okay.
we would have to get notification in order to know. So which is typically, through EMS non-fatal reversal. So it would only be data that we're aware of.
Right, so it would be if the public health folks that are with the fire department or EMS were called, where that occurs. So in those cases, that's probably sort of the escalated situation, because if it's been able to be reversed through naloxone, then that somebody has been administering, then that's that, unless the person needs further care, right? Okay, so thanks for clearing that up, because I just wanted to make sure, like, how are we actually knowing that? But we're clear that we're gonna miss some data unless there's been that 911 call, okay. But I think with all of the resources that are in certain areas, there's probably some resource sharing and some information sharing from people on the street saying, hey, this just happened, and then the public, so at least that can be there, okay. The other piece that I had, the other question I had is similar to sort of following up on my colleague from the 7th, in terms of one of the cases that I've been making is that things like this are happening in areas that have been disinvested and where there are several vacant properties. And we know that there was a sweep of the vacant properties nearby to make sure nobody was in there. It's really important to me that part of our vacancy reduction strategy, and I've said this publicly, is about reducing the vacants, whether it's through rehab or demolition, or very strategic stabilization of some of those, so that we're not, that they're secured in the areas that we need it most. And parts of this area, parts of other neighborhoods are actually not included in the target strategy related to vacant properties. And that's a problem. And I think that's a major problem. And so I'm hopeful that some of this work we can say to DHCD and to the state that are working on this, like, we need your help here, now, today, to address this issue. Because the vacant properties are not just, it's a health hazard, it contributes to all the challenges, and a lot of this is happening in areas that have been clearly disinvested. So I wondered if you've had conversations with DHCD and the mayor's office about saying, like, hello, we need some help here with this, because of some of these things that are happening.
So thank you for that, and certainly someone else can chime in. So I have been a part of the broader work group that is being run through the Office of Innovation that is looking at this vacant strategy. And one thing I'll note, though, when you look at the map of where vacant are, it does align relatively closely with, of course, we know, the black butterfly, which is often where we're seeing many of these overdoses occurring. And so I don't necessarily know the specifics block by block, but there is significant overlap when we look at vacant properties and where we're seeing overdoses, just like where we see other, health disparities and comorbidities. So I'd have to maybe drill down a little bit closer, but I think that there is quite a bit of overlap at how they're thinking about, like, which vacants to target and focus on already with where we're seeing, many overdoses.
I don't think that's the case, just based on my very in-depth knowledge of what's happening. So I think we just got to continue to make the case for better alignment to where the vacant strategy needs to be targeted into the areas that need it the most. And we can continue the conversation offline, but I've looked at some of the data and the maps also, and it's not aligning. So I think we need to really, really refocus based on that. Now, some people don't agree with me, but I think it's important that we do that, especially since we have these health disparities, not just overdoses, but all kinds of health disparities related to this as well.
And so just so I'm clear too, so when you say not aligning with where we see the majority of overdoses, or that's not aligning with the neighbors that have been selected?
Yeah, thank you for allowing me to clarify. Yeah, so there's a distinct catchment area that the Baltimore Vacants Reinvestment Council is looking at based on what the city was already emphasizing, as well as additional neighborhoods. And when you overlay that with some of our overdose data, those neighborhoods don't align with where the needs really are. Now, they are in some cases, but not in others. So that's what I'm saying, is that like, I would like to see a realignment to make sure that we're getting to the areas that really need it most, which means it's going to be harder. It's going to be harder, it's gonna take more money, it's gonna take more partnership, and that's, you know, some of the things that I've been working through. But because it is so endemic, I think that your help and advocacy to say, look, we need this strategy here. Yes, we have this acute need, but it would be something that another way to address this issue is through making sure that people have decent housing and that we don't have vacant properties in the area. So that's what I'm talking about. And then I also, in another hearing, said that I'd be happy to help with figuring out where are the ways to be able to make sure that people have decent housing as we're looking at the preventive side. So I offer that to you as well. Thank you. Thank you, Madam Chair.
Thank you so much. Councilman, did you have a official committee request?
Sure, thank you. I just wanted to make an official request for a follow-up, maybe in 30 days, on the notification system to see if we made any progress, to see what we come up with. Is that okay?
Sounds great.
Thank you.
Tylor, you got that? Thank you so much. Okay, you have it? Wonderful. All right. I want to circle back to the hours of operation for the street outreach. One of the bigger challenges that I believe we are seeing, and I've brought this up in many other outreach teams that we have executed in the city, we only go between certain hours. Talk to me about, if you could, talk to me about the integration of a 24-hour mobile outreach team that could be integrated and or collaborative with the MOHS outreach team. So Dr. D, can you talk to me about that?
Sure. And I may even have Mr. Bobby Harris come back up. But I think most folks probably know that as a part of the settlement, $15 million was allocated for 24/7 outreach. And the focus of 24/7 outreach, as compared to some of the other outreach that we're thinking about, is really to proactively address some of those psychosocial needs. So it's not necessarily for a person who is experiencing crisis, but it is for a person who is maybe looking for food or transportation, or needs some place to sleep. And so I called Bobby back up because Bobby is now supporting and leading the charge for that effort as BC More develops what that looks like, recognizing that we do have a system of outreach that's already in place, but that there are gaps within that system. And so Bobby is the lead on helping us develop that.
Yeah, no, it's been a busy first week. This is, Councilwoman Porter, thank you so much for bringing this particular piece up. I think a lot about folks that are being discharged from the emergency department or hospital in the middle of the night, re-entering our communities after incarceration in the middle of the night. I just want to actually give a quick shout out to MPAC and the incredible work that they're doing outside of central booking, as well as other mobile programs and community health programs. You know, when I spoke earlier about an integrated model that Dr. Jaraza just mentioned, this is the key component here, where we can have extended hours and integration, where we can address the need to find treatment that works for that person in that time and space, but we can also try to get to the roots of the social determinants of health needs that they have to support them. So my job working with BC More and in support of the city really is coming up with that integrated solution that can get out into our communities, again, not just in acute crisis, but have that presence across the week to be able to support people in need.
Wonderful. And do you have an ETA on when that plan will be developed?
Happy to give you that in time. We're looking at a plan by the end of this year, really to operationalize the overdose response strategy, and then looking into next year to find the right city partners and agencies to come together to build a model that that works for the scope and breadth of the need that we're experiencing in the city.
Perfect. Again, Tylor, if we could have a month-over-month status update regarding that plan, because I really believe that our peers are underutilized resource here in the city of Baltimore, and I believe we have very robust networks of peers that can be utilized, and so I want to make sure that we are doing it sooner rather than later. So again, Tylor, the official committee request is a month-over-month status update regarding this mobile street outreach and the operating procedures. Thank you, Councilwoman. Operating procedures as it relates to the strategy. Thank you so much.
Excellent.
The next question, and Dr. D, this is something that we've been talking about, but I want to go back to the conversation that Councilman Parker talked about as BPD being the central point in the DRI agency for the blitzes. The sustainability of those blitzes, I think, is a way that we can consistently show up in community and neighborhood, but it seems like right now, the blitzes are just like a one and done, and it doesn't seem like any continuity or thread between those blitzes within community. And Stephanie, I'm engaging you as well with regard to the community stabilization response from MOTSI. So Dr. D, could you comment on how you are integrating the data and also the findings from each of the blitzes and how you are incorporating other interagency partners as you go forward?
So I may actually take that question back because it is still a BPD-led effort. What I will say is that I have recently been engaging a lot more to understand the role of the Multi-Agency Inspection Task Force and how, as you note, to sustain the work, right? And so to make sure that we're going upstream and that we are working with the MAIF Multi-Agency Inspection Task Force to carry out formal recommendations that focus on upstream, not just downstream solutions. And so would love to take that back to BPD to provide additional information, but I myself have recently been participating more in those to just understand, again, how do we, I think it's still a tool in the toolbox, but of course we want to make sure that we're also going upstream and that we're tracking outcomes, to your point. Once a blitz has happened, are we achieving outcomes? Are we seeing actual shifts in that particular neighborhood? How are we following up with community members as well?
But I would even also just add to the conversation, I don't know if BPD is the right partner to lead. I think that's where I'm getting at, because when we're talking about the interagency approach of like housing, DOT, BC More, we are inherently, just by the simple premise of putting BPD as lead, we are saying that this is a public safety response, where in all the conversation, we are talking about how we cannot approach this from a simply public safety perspective. And so I wonder if there's an opportunity for us to reimagine if BPD is even needed as a leader of the MAIF. And Stephanie, did you want to say something?
Thank you. I'm Stephanie Mavronis, Mayor's Office of Neighborhood Safety and Engagement. I'm just building on what the Deputy Mayor shared. Right now, BPD is not the sole lead of the Multi-Agency Inspection Task Force. The Mayor's Office of Neighborhood Safety and Engagement partners every single week to help compile the agenda, make sure that some of our goals that come out of Coordinated Neighborhood Stabilization Response gets in the mix. BPD does play an amazing role, and specifically their community policing division, some of the work that we've done around neighborhood policing. Major Jenkins is a big part of that, but also the civilian staff of BPD. So really what we want to make sure we can do, we know that our majors in each and every district have their own insights. They know what the challenged corridors are in their district. They know what some of the emerging problems are. We want to make sure we can bring those insights to the table so that all of our operational agencies from DPW to DOT and beyond can really hear it from a public safety perspective, but that we don't just stop there. In fact, right before I was here, I came from a breakfast, kind of taking stock of the Multi-Agency Inspection Task Force process. We've done 55 blitzes to date, but this very question that you raised is what came up. We had community members in the room really to get some of their feedback on how can we make sure this isn't just a one-day effort? And I will say Monty has been doing some of that, making sure that beyond that one day, we're thinking about what our role is in stabilization as we move on. That's something that we want to formalize as we continue. But we are typically bringing what we've logged that day when all the agencies are out there together into the next meeting, tracking those deliverables and making sure that there is some follow-through accountability. So I think we have a good start, but I know between Monty, BPD, all of the partners, we're trying to think about what is like the 2.0 version of this multi-agency inspection task force, and just noting that before this task force existed, we still had our agencies really operating in their silos. This is just the beginning, I would say, of how agencies are coming together in a more strategic and thoughtful way to solve problems.
And I appreciate that, Director. I will also add, and thank you for the correction. I thought that BPD was the sole leader of this. Okay, so that makes me happy. Okay, that makes me happy. I want to also just add, and this may be for a different conversation, what is the interagency workings of, I know the CAO office has multiple interagency working groups in relation to like neighborhoods. How does the MAIF differ from those interagency working group meetings that I know that the CA and her team implement within, like in relation to our council offices? So like, for example, we had interagency coordinating efforts in like Westport, you know, where we talked that we brought DOT to the table, we brought DHCD to the table, we brought the health department, we brought BPD, we brought my office. What is the difference of that versus the MAIF? Or are they the same?
I might let Stephanie speak to that, or Director Mavronis.
I think in some ways they're the same. I think the multi-agency inspection task force, though, we're taking a citywide approach. We're looking at all of the areas we focus on over time, and then typically using those meetings to preview where the next blitz is going to be, while also spending a part of that meeting doing follow-ups. So some of the specific areas of focus that come from the city administrator's office, they may involve some of the same agency players, but of course that is a meeting or a working group solely dedicated to the challenges in that one community. But I will say that when we have a focus like that, whether it's through a coordinated neighborhood stabilization response, whether it's through one of the areas identified by council members and the city administrator, we're bringing those into that meeting too, because really
one is folding into the other.
Yes.
Okay.
Because the goal is our operational agencies, they're tasked with a lot. Part of this meeting is making sure that from a priority level, we can help set the agenda. This is where we really need focus. This is where we need to see follow through. This is how we want the operational agencies to kind of manage their time and make sure that we're achieving the same goal. And so I would say in those ways, you know, we're using a very similar model, but some of our neighborhoods require a deeper level of conversation. And I think something we want to do with the multi-agency group moving forward is making sure that as much as we're using the 311 data, the 911 data to proactive, and our observation to proactively identify what we see in community, I think the next phase of this is all about sustainability also through not just stabilization, but community participation in those efforts.
Thank you so much. All right, colleagues, any other questions?
I'd like to just follow up with that point. And I think, because we talked about this in the Public Safety Committee regarding the multi-agency response folks. And once again, I'm always thinking about systems. And what I think is actually happening here is we as the city government are trying to come in and like prop up communities, but we can't do that indefinitely. And so I sort of beg the question here and how we're sort of doing this. If there's a way for us to empower communities, community associations, churches, neighborhood associations, whatever the case is, so that they can then stand up, do some of the cleanup, do some of the community building, and what part we can do to empower them in that effort. Not an answer that you need to have today, but as we think about this model, we can come in, sure, we can prune trees, we can pick up trash, we can clean up graffiti and then go away and come back in a month. Or we can come in, do that work, and equip the community to have a system for dealing with that and interacting with agencies without, you know, the mayor's office having to come in with every agency for, you know, a couple of days. Just something to think about.
Torrance?
Thank you, Madam Chair, and it was good seeing you today, Stephanie. So similar to that, Councilman Conway, in the 7th District this morning, we had leaders from across the city with our multi-agency inspection task force discussing that very thing at Touchpoint. It's been a pleasure to see it evolve because now I have community leaders who feel like they can believe that city government can work together on a common goal, but also residents feel that they are adding to the innovation that the agencies are experiencing too. I'll give you an example. I have a resident who has been on us about the Wahiden and Tawanda Avenue in terms of the dumping and the illegal cars. Now we got out there last week and we worked with DOT with residents. We now have no stopping signs. We actually are issuing a citation for $15,000 for runoff into our waterways, right, because of the vehicles. It is the residents who are being our eyes and ears, but also they're working with us to clean it. And I just want to say that, like, this is a different approach because then it is recreating the agency and efficacy of our neighbors to actually be a part of government and not government just doing something for them.
Great. Thank you so much, Councilman Torrance. Any other questions? All right. Definitely want to thank you all for joining today. Just wanted to highlight for the next legislative oversight hearing, I will be specifically looking for the data to provide the measurable outcomes to that overdose response strategy. I think we have a lot of conversation related to those integrated solutions and how they're linked to the overdose strategy. So if you could, over the next couple of months, as you begin to gather data, be prepared for the next legislative oversight to discuss those measurable outcomes and the data supporting, and also any types of sustainability measures that come from that plan intermediate. I know it's going to be long term, but where we are to date. So thank you all so much for joining.
Oh, Madam Chair, there was a resident here who wanted to. I don't know if you're taking testimony on the LO. But
We took testimonies in the beginning, but I would.
Oh, got it.
Yeah, no worries. I would welcome. We can open up public testimony again. Did you want to testify? Yes. Thank you so much for coming down to City Hall and sharing. If you want to press the button, just make sure to state your name first. Thank you.
Yes, my name is Thelma Davis. I'm so new to this. Somebody told me I should be here, so I came.
Thank you so much.
So I have a residential treatment facility, 3.1 residential treatment facility for women, Miss Thelma's Oasis LLC. I'm also a recovering addict. November the 13th will be 36 years that I've been clean.
Congratulations.
Thank you. And my reason for us opening a business and allowing these women to come in and love on them and help take care of them to get on the road of recovery was because of just my experiences and my treatment and my recovery. What I found is that a lot of these women come in, they real broken, and the main thing is they need housing. Our program is the step where from our program they should be going into their own house, being able to take care and live, in a recovery setting on their own. And I find that these women it's just not available. The housing list is so long. And they doing the work. They doing the work that they need to do to be able to get into their own place, but it's just not available. My other concern was, and reason for me getting into this business was that I find that the recovery setting, they are piling maintenance. Like, maintenance is the way, Suboxone and methadone. And for me, that just have not been my journey. When I got clean, abstinent was the key. They supported abstinent, because for long-term recovery, I just believe that abstinence is the key, and so how are we, and I hear everybody talking, and I'm not a professional, I'm not.
You are.
I am in life.
Yes, you are.
Right, and through my own personal experiences. But what are we gonna do for long-term treatment, total abstinence, so people in recovery can really reap the benefits of what it's like to be quote-unquote normal.
And I thank you so much. And first, I want to thank you for sharing your story. I want to commend your courage for not only just sharing your story, but also coming to City Hall and testifying. So I'm always going to be appreciative of folks that take time out of their day and come to City Hall and engage within this public process. So thank you so much.
Thank you for having me.
Secondly, you bring a very valid point with regard to the housing instability that most people in recovery are dealing with today. And we certainly have many champions of housing on this committee, and we are actively looking at ways of how we can increase housing, particularly for those in recovery. We have many initiatives. The mayor has done many initiatives from a housing perspective. I know that I am working on one at a state level perspective of how we can integrate housing, because we know that if there's instability with some of those foundation level symptoms that we're seeing in a person, whether it be housing, whether it be food, whether it be employment, all of the social drivers of health, a person's not going to truly be able to focus on their recovery and what they're trying to do. So you have an absolute commitment that we are working not only within this committee and across our subcommittees, which include housing, education, labor and workforce and development, but we are also working from a hierarchical perspective, looking at state level partnerships and also federal level partnerships as well, because we understand that all levels of government are going to have to be engaged in this process if we're ever going to truly, and I hate to use the word fix this process, we have to be able to sustain true recovery, and that's what we're looking for, not only just from the bandage perspective,
Yes.
but really looking at the root causes of how we can ensure that someone has a better quality of life, whether
Yes.
it be actively using, whether it be in recovery, or in your instance, whether it be in abstinence. I want to
Yes.
preface those three areas because one of the issues that we're seeing is that some folks are not ready for true abstinence, and
Yes.
we have to be mindful of that. And so as we look at the programming, not only within this committee, but also within our health department, within our community-based organizations, we have a gradation of programming that wherever you fit into the process,
Yes.
you will be able to engage with whoever, whether it be a person in recovery actively using or one that wants to completely go abstinent. So you are definitely spot on. I want to share, I want to make sure that you stay engaged with the process,
Yes.
because as we are talking about this, as we are engaging, particularly from my committee, we want to hear from actual providers.
Yes.
A lot of the programming, a lot of the laws that we will be hopefully executing on behalf of this committee will enhance and or impact providers like yourself. And so definitely stay engaged in the process.
Yes, because our goal is to, one day, because this is our first house, we are a licensed facility through the state of Maryland and through Joint Commission. And so our goal is to have our women transfer from one state of care to being in their own apartment where we will provide, because we don't just want them to come in and start their recovery and just throw them out there on their own. We want to be a big support system for them as they able to move forward in their recovery. And so, yeah.
Yes, thank you so much. Really
you for
appreciate
having
you.
me.
Thank you. And thank you so much, Tylor, for mentioning that.
Thank you.
Any other public testimony before we convene today's hearing? All right, hearing and seeing none, thank you all so much for joining.